In this video, we will look at focal slowing and attenuation. There are several important considerations when looking at focal slowing and attenuation. It is important to recognize and document the location. Does it involve a region or the entire hemisphere? The frequency. Is it mainly theta activity, delta activity, or is there a mixture of frequencies? Is the slowing continuous or intermittent? And is it rhythmic or polymorphic? These elements of focal slowing can be helpful in determining the possible clinical significance of the abnormalities. We will review several examples of focal abnormalities in this video, and you will see that there is a broad range of focal abnormalities on EEG, with an even broader range of clinical correlation. Mild intermittent focal slowing can be one of the most difficult EEG abnormalities to identify. While recognition of mild intermittent focal slowing is often very easy for the experienced EEGer, this is often the source of a lot of confusion and frustration for people learning how to read EEG. This is an anterior-posterior bipolar montage with left hemisphere on the top, midline electrodes in the middle, and right hemisphere on the bottom. This patient has some mild intermittent focal slowing, mainly in the theta range. This may be difficult to see at first, but I will provide you with some recommendations on how to look at an EEG in order to identify these sorts of abnormalities. When you're first reading EEG, one of the best things that you can do is simplify your reading by going second by second through the page. In each second, it is a good idea to compare analogous head regions. For example, in the first second of this page, we can compare the left temporal region to the right temporal region. Already we get the hint that there might be a slight difference between these two regions. In the anterior temporal regions on the left side, there is a hint of a theta or delta wave, which we do not see in the analogous region on the right. Moving forward a few seconds, take a look at the left temporal region in this 3 seconds. Again, compare it to the analogous head region on the other side. Here we can see that there are several waveforms in the theta and delta range that we see on the left, especially in the left anterior temporal region, that we do not see on the right. Therefore, we can say that there is some focal slowing or some focal polymorphic, i.e. not rhythmic, theta and delta activity in the left temporal region not seen on the right. This is an indication of some mild focal cerebral dysfunction, but it is a very nonspecific finding that can be seen in a lot of disorders. Here I have switched to an average reference montage. As I have mentioned in previous videos, it is sometimes easier to see focal slowing on average reference montage as opposed to bipolar montages. Again, look at this string of 3 seconds and compare the left temporal region to the right temporal region. Particularly, compare F7 and T7 to F8 and T8. You can clearly see that there are some medium voltage theta and delta waves on the left side that are not seen on the right. This is the same patient during drowsiness or light sleep. Here you can see that there are clearly high voltage delta waves intermittently in the left hemisphere, maximal in the left frontal and temporal regions, that are not seen in analogous head regions on the right. As you look for focal slowing, it will take a long time to review a routine EEG recording. However, with experience, you will become more proficient at recognition of patterns, and it will be easier to screen for this focal slowing. Here is a slightly different example of focal slowing or focal cerebral dysfunction, but again, the same approach works. Starting with the first 1 or 2 seconds, compare analogous head regions on one side and then the other. If we do this for the first few seconds of this recording, we can see that there is a nice alpha rhythm on the left side, and on the right side we do not see much of an alpha rhythm, and instead we see polymorphic, i.e. non-rhythmic, delta and theta activity. This seems to be most prominent in the temporal region, but also extends to the parasagittal region as well. If we continue across the page, comparing left to right, we can see that rather than being intermittent, as with the last recording, this slowing is continuous. Therefore, we would conclude that this patient has continuous polymorphic theta and delta activity in the right hemisphere, maximal in the right temporal region. This suggests more significant focal cerebral dysfunction and can be seen in clinical scenarios such as a focal structural abnormality like stroke or tumor, or postictally, It is important to remember that focal polymorphic delta activity could represent a postictal phenomenon. For example, if a patient comes in with unexplained decreased consciousness, has normal imaging and a normal exam, but has focal polymorphic delta activity, it could be that they had a seizure prior to the EEG being connected. This is actually the case in this patient scenario. This patient had completely normal neuroimaging, but had unexplained altered consciousness, and it was later found that this patient had localization-related epilepsy arising from the right hemisphere. After 24 hours, his EEG normalized, and he has been well controlled with no further seizures while taking anti-epileptic drugs. Here is yet another example of focal slowing. We can see that this slowing is on the left side of the head and seems to be most prominent in the left temporal region. On this montage, I have included the inferior temporal electrode chains here on the left and here on the right. You can see that there is continuous focal delta activity in the left hemisphere, and you can see, as opposed to the prior recordings, this activity is quite rhythmic at about 2 or 2.5 hertz. Therefore, we would call this lateralized rhythmic delta activity. Rhythmic delta activity might indicate a slightly higher predisposition towards seizures, and therefore these patients need to be watched carefully. This recording was taken in a patient with temporal lobe epilepsy. Here is this patient's MRI, where you can see a very small atrophic hippocampus on the left side. This patient has epilepsy due to left mesial temporal sclerosis. This is one of my favorite teaching EEGs because it shows an entire clinical story on one page. Again, the organization here is left hemisphere on the top, midline in the middle, and right hemisphere on the bottom. Comparing left to right, second by second, we can see that there is a significant difference between the left hemisphere and the right. Whereas there is both theta and alpha activity in the right hemisphere, we do not really see very much alpha activity on the left. This suggests that there is some attenuation of faster activity. Instead, we see this very slow delta activity at a rate of 1 or 2 hertz with some superimposed theta activity, although not nearly as well developed as on the right. Therefore, we would say that there is focal cerebral dysfunction on the left, manifested as focal polymorphic slowing and focal or lateralized attenuation. Let's look at some of the other features of the EEG that are not nearly as obvious. Here you can see that there is very prominent muscle activity in the left temporal region, and we see almost no muscle activity in the analogous right temporal region. This would suggest that some of the muscles in the right temporal region, such as the temporalis muscle and some of the facial muscles, are activated on the left but are not activated on the right. If we look in the second half of the page, we do see that there is some muscle artifact in the FP1 and FP2 channels on both sides, and therefore the frontalis muscle is likely functioning fairly well on both sides. Therefore, we can conclude that this patient probably has some temporalis and possibly lower facial muscle weakness on the right side. Putting it all together, you could say that perhaps this patient has a lower motor neuron facial weakness on the right due to cerebral dysfunction on the left. Finally, if we look at the EKG tracing, we can see that we have an irregularly irregular tracing with no obvious P waves prior to the QRS complexes. Although we cannot make any definitive conclusions about the EKG rhythm, we might suspect that this patient could be in atrial fibrillation. Putting it all together, this patient has left hemispheric dysfunction on EEG, right facial weakness, more in the temporalis than frontalis muscles, which suggests upper motor neuron facial weakness, and possible atrial fibrillation. One might conclude that this person had an embolic left hemispheric infarction due to atrial fibrillation, producing right upper motor neuron facial weakness. This is this patient's CT scan, and here you can see that there is an evolving infarction in the left MCA territory. Here is one last example of a focal abnormality. Again, comparing left to right, we can see that there is some polymorphic slowing in the left hemisphere that we do not see on the right, particularly in the left temporal region as compared to the right. In addition, we see that there is higher voltage of some of the faster activity in the alpha and beta range in the left posterior head region as opposed to the right. This is a breach artifact. I have drawn this very crude diagram of a brain in order to illustrate the breech artifact. This is the brain. This is the skull. We will put an imaginary EEG electrode here. Low-frequency waveforms, generated by the cortex, have an easier time passing through a dense object, such as the skull, and so all of these are seen easily by the EEG electrodes. Higher frequency waveforms, in the beta and higher range, have a more difficult time traveling through the dense skull, and so these are seen at lower amplitude and less prominently than lower frequency waveforms. Now I have put a break in the skull here. If we have an electrode adjacent to this region, higher frequency waveforms pass more easily through the breach in the skull than they do through the intact skull. So in the particular part of the head where there is a breach in the skull, you will have more prominent high-frequency activity, as we saw in the preceding example. A more concrete example of how a dense object is a high-frequency filter is to think about the bathroom door at a music club. When you are in a music club, you hear a mixture of both high and low-pitched frequencies. However, when you go to the bathroom, usually you only hear the thumping of the bass, the low frequency, after you close the door. When you are finished and open the door, all of a sudden high frequency becomes more obvious. In a similar way, the skull acts like the bathroom door, filtering out some of the high frequencies and leaving only low frequencies. When there is a breach, it is as if the door is open in one particular place, and so high frequencies leak out and are seen more easily. This patient has a prior craniotomy in the left parietal occipital region, and this explains the excess of high-frequency activity in this region. In this video, we have reviewed several examples of focal slowing and attenuation and their clinical significance. To review, it is important to remember the location, the predominant frequency, whether or not it was continuous or intermittent, and whether or not it was rhythmic or polymorphic. This is meant to be an introduction to focal abnormalities, and you will see that this video showed just the tip of the iceberg of focal abnormalities on EEG.